Thank you all for being here. And as you can tell, we are recording this meeting. We'd appreciate if everyone could be on mute and we can make this recording available after the fact. My name is Emily Peck. I'm the technical director for the HEARD project based at URC. I'm really excited to be here today and to welcome you all to the 20th meeting of the MHPSS Learning Collaborative. The Mental Health and Psychosocial Support Learning Collaborative has been supporting evidence to inform implementation for more than 3 years. We are excited to share with you some findings from the first phase of studies and would like to signal that going forward from here, we will be expanding our scope in terms of focus and inclusion of participants. In particular, we're going to be exploring community-based mental health interventions. So more to come on that in our next quarterly meeting. As we expand and evolve the group, I'd like to welcome our special guests, in particular those from USAID and USAID missions, GIZ, the WHODAS investigators, and partners from across the Implementation Science Collaborative and related projects. If you are new to the Learning Collaborative, we invite you to put your name and your affiliation in the chat. Let's get right to it. So today we will have 2 presentations, one that highlights learning from across psychosocial support intervention effectiveness trials, and another on findings from the validation of the WHODAS, or the World Health Organization Disability Assessment Schedule. And then we will end with a panel discussion. So I'd like to remind you that at any point you can type questions in the chat. If we don't get to them in this meeting, we will follow up with answers. So without further ado, we'll get started with our first presentation on community-based PSS interventions for trauma-impacted communities in low and middle-income countries, implications for research, policy, and practice by Dr. No and Dr. Greene. Thank you.
Welcome everyone to our webinar. Today I'll be talking about the cross-study impacts of psychosocial interventions that have been developed for trauma-impacted communities in LMIC settings. We'll talk today about the implications for research, policy, and practice. My name is Vicki No, and I am an associate professor here at the CUNY Graduate School of Public Health and also the director for the Center for Innovation in Mental Health. I'll be joined by Claire Greene, who's also a professor at the Columbia University. And with that, let's begin. Thank you. So briefly, I want to give you a little bit of a background on the ISC Mental Health and Psychosocial Support Learning Collaborative. We were established in 2020, and our group is basically a learning collaborative that is focused on having a global network of practitioners and researcher pairings, along with policymakers, donors, and other stakeholders. We regularly convene to share and consult the group on intervention studies and collaborate on evidence and use products and consider emerging priorities. Our collaborative seeks to promote cross-site learning and enhance implementation efforts. We also seek to synthesize research and advance the evidence base. And lastly, accelerate the evidence and use processes for community-level mental health and psychosocial support interventions. We invite you to join our collaborative and to help us expand the work that we are doing. While I'm the one sharing the results of this work, we have many people to thank for it. This team represents members from each of the study teams and also from URC and CUNY SPH. You'll be hearing from some of the members during the panel discussion a little later as well. So the cross-study evaluation consists of 5 different studies from different parts of the world. First is baby-friendly spaces in Bangladesh. Second is nurturing families in Jordan. Third is journey of life in Uganda. Fourth is community support groups in Colombia. And then fifth is Entre Nosotros in Panama and Ecuador. So one of the main reasons why our portfolios focus on mental health and psychosocial interventions for trauma-impacted communities in humanitarian settings is that there is actually not very much research in this space. Many of the studies that focus on mental health and psychosocial support are actually they lean more on the clinical side, and so they're more mental health treatments that are often manualized and for clinic populations like those with depression or anxiety. And there is much less work focused on more general psychosocial support interventions There's a lack of rigorous, outcome evaluation and implementation evaluations, and certainly a lack of replication studies across multiple contexts, particularly in more humanitarian settings. And so our initiative really, strove to address this gap and to conduct more comprehensive evaluation to assess for effectiveness for psychosocial interventions in displaced and conflict-affected populations. And we wanted to make sure that we consider diverse regions and contexts and think about implementation outcomes and processes along the way. The work that we're doing, really focuses on trying to harmonize outcomes across the studies so that we can learn, can combine our forces to understand what actually works across multiple contexts, and also to systematically document adaptations for program implementation, including adaptations for intervention content, provider training methods, and community engagement approaches. When we began our learning collaborative, one of the first goals for us was to set up harmonization workshops for us to identify key mental health and psychosocial support indicators and measures that were priorities across the studies. And so we had 4 workshops focused on 4 areas. One is distress, which, where we identify Kessler 6 as the measure that all the study teams would use. Functioning, we use the WHODAS 12. Well-being, we use the Personal Well-being Index. And coping, we use the Brief Cope. We also harmonize key demographic variables such as gender, employment, marital status, and implementation, provider type and setting type variables. We also developed a cross-study data repository and began monthly cross-study work group meetings to review findings and identify critical implications and recommendations to do this cross-study evaluation. Now I'm going to briefly share the key findings from our cross-study evaluation. First, I'm going to share with you a little bit more about the intervention characteristics across the studies. As you can see in this table, we have the projects outlined by population, setting, provider, intervention components, and also the comparison group in the evaluation. There's quite a bit of detail about each of the studies, so I'm not going to go over all of it. But basically, the cross-study evaluation included all 5 studies that are participating in our AIMIG PSS Learning Collaborative. They're all hybrid implementation studies that are evaluating a psychosocial intervention delivered in community settings for populations with high exposure to trauma, violence, and/or displacement. So 2 out of the 5 studies were conducted in refugee camps. 3 out of the 5 involved task sharing with non-mental health community providers, some of whom were peer or lay counselors. And then in terms of the intervention components, they included a range of psychosocial components, including psychoeducation, problem solving, stress management, and coping skills, parenting skills, family support skills, and social support. There was also quite a bit of variability in terms of the comparison groups used across the studies. 2 out of the 5 compared the intervention with waitlist control. There were also several studies that compared the standard intervention with an enhanced usual care. Therefore, they included an active control group. For example, Entre Nosotros compared a standard women's group with one that offered stress management. The Nurturing Families study compared their intervention with an enhanced usual care, and then Baby Friendly Spaces compared their standard intervention with an implementation enhanced approach. So the majority of the studies found significant improvement in distress from baseline to post-intervention, but only half found significant differences between the intervention and control groups. And only 3 of the studies included well-being as part of their outcome measures, and 2/3 found significant differences between baseline and post-intervention. However, only 1 out of the 3 found differences between the intervention and control group. In terms of the functioning measure, only 1 study found an intervention effect on functioning, and that was baby-friendly spaces. For coping, there were 3 studies that included coping, and 2 out of the 3 found improvements over time, but only Entre Nosotros found intervention effects. So in conclusion, there were variable effects across these harmonized outcomes for mental health and psychosocial support. Although we found inconsistent impacts for harmonized outcomes, other outcomes identified by the study teams did find significant effects on the study-specified outcomes. So, for example, in the Journey of Life in Uganda, significant effects were found for social support and parental outcomes like parental warmth, undifferentiated rejection, and violence against children attitudes. For the community support groups in Colombia, intervention effects were found for more targeted mental health outcomes such as depression, anxiety, and PTSD. For the Nurturing Families program in Jordan, improvements were found for parenting practice, emotion regulation, and impact on self-defined problems. And then lastly, for Entre Nosotras, improvements were found for a sense of safety and community connectedness.
Hi everyone, my name is Claire Greene, and I am an assistant professor in the program on forced migration and health at Columbia University. I had the privilege of working with HIAS and partners at University of Copenhagen on the Entre Nosotras project in Ecuador and Panama. I'm sorry I can't be with you all today for the webinar, but I'm happy to have the opportunity to share some of the lessons learned from this cross-study analysis and process that Dr. No just described. First, I wanted to share some key takeaways regarding the effectiveness of community-based psychosocial interventions. In general, we saw stronger effects in most of the studies for the psychological distress outcomes, and fewer within or between group differences for other cross-study outcomes such as well-being, functioning, and coping. It's important to note that there was heterogeneity across studies. For example, the study I worked on in partnership with HIAS largely targeted well-being and specific coping strategies. In our study, we found larger changes over time in those outcomes as compared to distress and functioning, which was different from some of the other studies, I should say many of the other studies in this group. As noted on the second point on the slide, the mechanism of change for some of the other interventions was focused on distress reduction, and there was quite a bit of diversity in these hypothesized mechanisms of change across studies, which may explain some of the differences we observed. Another factor to consider when interpreting these cross-study effectiveness findings relates to the profile of the target population, or the study population, and the intervention characteristics, specifically the alignment of these factors with the outcomes that we were measuring. Much of the existing evidence on mental health and psychosocial interventions are focused interventions that enroll people with elevated distress or symptoms of common mental disorder, for example, and are designed to target these symptoms. In some of the studies within this consortium, the eligibility criteria were much more broad and actually intended to reach population with less impairment and fewer symptoms. As noted on this slide, the average levels of impairment in the study were already quite low by design, which didn't leave much room for improvement, and perhaps in some of these studies we could have captured more meaningful change on other outcomes, such as more social and community-focused outcomes. A third important factor to consider when interpreting these findings is the heterogeneity in comparison conditions across studies. 3 of the 5 studies had an active or enhanced waitlist control condition. Therefore, the contrast between the experimental and the comparison group should be interpreted quite differently to those studies with a waitlist control, for example. And these differences in population eligibility, comparison groups, and mechanisms of change are major sources of heterogeneity and variation, which we need to consider when interpreting these cross-study outcomes. Lastly, several of the studies also measured other outcomes and examined certain subscales of some of the cross-study outcomes and also used qualitative data to explore other intervention impacts, both positive and negative. While we have focused mostly on the cross-study outcomes in this presentation, it's important to note these other findings and also emphasize that in this qualitative data that we collected across studies, participants generally indicated positive impacts of the interventions, some of which were consistent with the quantitative outcomes that we measured, and also other impacts that were not directly measured quantitatively. A couple of other key findings from this cross-study process relate to measurement and context. Both a strength and a challenge of this cross-study analysis relates to the measurement of mental health and psychosocial outcomes. In an effort to facilitate this cross-study analysis, most of the studies, as Dr. No described, included a core set of outcome measures related to distress, well-being, coping, and functioning. However, the psychometric performance of these measures varied across studies, and while all the studies underwent a process of adaptation of these core measures in order to fit the local context, it's possible that they still didn't perfectly fit the population's expression of distress or coping strategies or other constructs. The variation we observed in the primary outcomes thus may be due to both differences in the characteristics of each of these studies that we shared on the previous slide, but also the measurement error and variable performance of the assessment tools. Some of the measures consistently presented challenges across most of the studies. For example, the coping measure included items that did not fit many of the study contexts, and the performance of the subscales was variable. Cultural and contextual factors are likely to influence adaptive coping strategies, which may explain why we observe this heterogeneity in the performance of a standardized coping measure used across studies. To account for these measurement issues, several studies included additional outcome measures that we mentioned on the previous slide and have been previously used or validated in the study population. And this strategy of incorporating a combination of standardized and localized measures that align with the intervention's theory of change and intervention targets may facilitate pooled cross-study analyses while also preserving tailored measurement of constructs that are shaped by culture and context. Also, these studies were implemented in quite dynamic contexts due to the social and political situations, the COVID-19 pandemic, and other factors, some of which were shared across studies while others were quite unique to specific study contexts. Some of the challenges this presented included barriers to attendance or retention, having to pause the intervention for periods of time or adjust the mode of delivery, as well as many other factors. When implementing these types of interventions, especially those that have a community-level component, we must consider these contextual factors and incorporate flexibilities into their implementation to accommodate these changing conditions. There's also a lot that can be learned from testing out similar interventions across contexts to learn about the impacts of these contextual factors on implementation as well as effectiveness outcomes, and to facilitate cross-context learnings and knowledge sharing. Lastly, we'd like to end with a few key recommendations. The first is the need for formative pre-implementation research. Especially if the intervention is new within the study context, we found that this type of formative work was crucial to tailor the implementation strategies and make adjustments to the intervention to align with community needs. We also learned a lot through our mixed methods evaluation approach. There were several program, process, and outcome-related learnings that emerged in our qualitative research that we would have missed if we'd only captured outcomes quantitatively. The qualitative research was also useful for triangulation with the quantitative findings and explaining any of our surprising quantitative results. We spent much of this presentation discussing the strengths as well as the challenges we experienced that relate to measurement, specifically quantitative measurement, and the cross-study analysis. Most of the available measures that we found when we were starting this process and that have strong psychometric evidence are really distressed and problem-focused measures. And together we agree that there's a need to develop and evaluate a broader set of measures for psychosocial and community-level outcomes. Furthermore, these community-level outcomes are also very important but often overlooked in much of the research on psychosocial interventions. We often focus on measuring individual-level outcomes among groups of individuals who participated in an intervention. Measuring these community-level outcomes often requires additional resources to adequately and validly capture outcomes and impacts at this level, but particularly for interventions that are targeting these higher-level social and community processes, further examination of these outcomes and developing feasible methods for measuring these outcomes in dynamic contexts is needed. And finally, much of what we learned through the course of this study related to implementation and the factors that have surfaced to explain the differences in outcomes across studies as well as within studies are largely related to the heterogeneity in design or implementation across the studies and over time. So we agree that further examination of the critical implementation determinants that affect both effectiveness and implementation outcomes is critical to advancing our understanding of how and for whom and under what circumstances these psychosocial interventions are beneficial. So thank you for your attention. We would like to acknowledge the generous support from USAID, the implementation, leadership, and coordination support from URC, as well as the cooperation and collaboration of all partner organizations who are involved in this learning collaborative. Thanks, everyone.
Thank you so much for that presentation. A lot to digest. If you want to learn more, there will be a special edition coming out with findings from across the studies. We can also share links to our website and previous material recorded on YouTube if you want to dig into the details of those studies more. But in the meantime, we'll move along to our next presentation, which will feature members from the work group that has been doing the study of the 12-item WHODAS or World Health Organization Disability Assessment Schedule. So let's hear about that and then move into the panel. Thank you.
Good morning, everyone. My name is Weanne Estrada-Magbanua, and I'm a project manager at the CUNY Center for Innovation in Mental Health. Today, I am pleased to share with you, together with Dr. Sabrina Hermosilla, the findings from our validation study of the 12-item WHODAS in displaced and conflict-affected populations. The presentation today is a product of the work of the MHPSS Learning Collaborative's WHODAS work group, composed of Dr. Flora Cohen, Dr. Sabrina Hermosilla, Dr. Sarah Murray, Dr. Victoria Ngo, and myself. This work was conceptualized during the Learning Collaborative's harmonization workshop. So as we were identifying outcomes for the study teams to use, we realized that there has been little to no factor analytic work that's been done on the 12-item WHODAS for trauma-impacted populations. As practitioners and researchers in this field, we are aware that displaced and conflict-affected populations are at high risk of encountering post-migration living difficulties, such as unstable housing, diminished access to healthcare, and disrupted social support. All of these have an effect on their functioning, which is conceptualized as the dynamic interaction between a person's body functions and structures, their daily activities, their participation in all areas of life, and their surrounding environment. Accurate assessment of functioning in these settings using a sound measurement tool is necessary to identify individuals of highest need in these resource-limited settings. Which brings us to the 12-item WHODAS, which is the shortened version of the full 36-item WHODAS. The WHODAS was a measurement tool developed by the WHO over a span of 2 years by a task force of international experts involving a review of over 300 existing instruments, a systematic cross-cultural applicability study, and a series of empirical field studies. The 12-item WHODAS is composed of the questions you see on the right, with respondents indicating the level of difficulty they have for each item using responses ranging from none to extreme or cannot do. The 12-item WHODAS explains 81% of the variance of the 36-item version and allows for the computation of one overall functioning score. So while both the 36-item WHODAS and the 12-item WHODAS have been validated extensively in the general population and for certain health conditions and across a variety of cultural settings, to our knowledge, there has only been one validation study of the 12-item WHODAS in humanitarian populations, and the results of ACTAR study is indicated on this slide. This indicates a clear gap in the evidence, especially as the concept of functioning may take on a different meaning in these settings due to the ever-changing conditions and limited opportunities for performing regular activities of daily living. So validating the 12-item WHODAS is particularly useful as its brief nature makes it a favorable tool in these contexts where shorter and more rapid assessments are preferred. Therefore, our aim for this study was to examine the psychometric properties and validity of the 12-item WHODAS on displaced and conflict-affected populations. We applied several methods to reach this goal. So first, to identify eligible cross-sectional baseline datasets, we conducted a broad search of the literature using the keyword WHODAS, which resulted in 528 articles. We screened these articles on Covidence, applying the following inclusion criteria. First, the study must have utilized the 36-item or 12-item WHODAS. It must have been conducted in displaced or conflict-affected populations. And third, we included an established measure for trauma and depression. We included this last piece because in the future we want to do subgroup analysis on populations with trauma and depression. So in the end, 14 studies met this inclusion criteria. We reached out to these 14 studies, and of these 14, 5 signed a data sharing agreement with us. These were the data sets that were included in our final set. We had studies from Uganda, Ethiopia, Pakistan, and Malaysia, as well as one study of male asylum seekers from several countries in Africa that were resettled in Italy. As you can see from the participants column here, participants consisted of refugees, asylum seekers, and residents in an armed conflict area. As you can see by the column on the WHODAS language, we also took note of how the studies were administered and translated. Overall, our full sample consisted of a total of 2,400 participants across these 5 different datasets. The reference for each study is included in the last column, and I would like to take this time to particularly thank all of these investigators, some of which are present with us here today, for sharing their data with us and facilitating the accomplishment of this analysis. For our analysis, we took a close look at all the variables across the different data sets and conducted an extensive harmonization process, which involved us communicating and convening with the original investigators to more closely understand how they had originally defined, conceptualized, and categorized their variables. We coded study-level variables such as the type of study, geographic coverage, survey administration mode. We also harmonized the age, gender, education, and employment variables and collapsed them into a set of like variables. We also harmonized how the 12-item WHODAS variables were coded, as well as the trauma and depression variables. We then merged all of these together into our main dataset. For the statistical analysis, we calculated frequencies, means, and standard deviations for the demographic and functioning variables. We calculated reliability and internal consistency, with good reliability identified as having a convex alpha greater than 0.7 and item total correlations greater than 0.3. We conducted a confirmatory factor analysis, which Dr. Hermosilla will explain in more detail later, as well as goodness of fit tests using chi-square, RMSEA, SRMR, CFI, and TLI. I will now pass this on to Dr. Hermosilla to review the key findings and main points.
So much, Weanne. As mentioned, my name is Sabrina Hermosilla, and I'm an assistant professor at Columbia University. I'm going to walk us through the key findings and implications of this work. So Weanne went over the specifics of the individual studies that went into the pooled analysis. This slide goes into the characteristics of that overall pooled sample. So we have data on 2,400 individuals, and we were able to harmonize variables around gender, age, education, and employment. For gender, a little over half are female. For age, the far majority are adults. For education, we're split. A little over half did not complete primary education, whereas a little under 49% did complete primary. For unemployment, we have about 65% reported being employed or having domestic duties. We have some of this information continuously as well. So the mean age in this sample is 29 years old. For the WHODAS itself, why we're all here, the mean score is 15.9. As a reminder, the range goes from 0, which indicates nearly no impairment, to 48, which is highly impaired or disabled. So that's a sense of the sample. Let's look at the items themselves. Here on the left, you'll see the different variables. These are each of the 12 items in the WHODAS. Next, we have their mean, and then finally, the corrected item total correlation. So from the low side, getting dressed or washing your own body, those have the lowest means of 0.91, 0.97. And then on the high side, we have how much have you been emotionally affected by your health condition? And this is around 1.73. Finally, the Cronbach's alpha is 0.93. So we conducted confirmatory factor analyses, for which Weanne walked you through. We did 3 models here, the first being a one-factor solution. Why? Because the original 12-item WHODAS was designed to have one global disability factor. Next, we fit a 3-factor solution, because when we went to the literature, the only humanitarian population that had an EFA conducted on it had identified a 3-factor solution. And so here's a representation of that. And then finally, we also fit a 6-factor solution. And this is because the original 36-item WHODAS was actually designed around 6 main domains. And so theoretically, it made a lot of sense to see if we could identify those as well in our reduced 12-item WHODAS. So what did we find? Before I tell you, we want to go over what these fit statistics are. So Weanne already gave you some indication about what they were. There's a little cheat sheet at the bottom. Roughly, the RMSEA, smaller is better, fit. For the CFI and TLI, bigger is better fit. And then for the SRMR, again, smaller is a better fit. When you see the numbers that we're going to put up in just a moment, if a fit statistic meets these criteria, meaning it's indicating it's a good fit, then we highlight that in orange. Otherwise, everything else is in black. This is a way we can compare across the different models. So for the one factor structural, you'll see only at the SRMR did it meet the good fitting criteria for model fit. For the three factor, we see the same thing. But then for the six factor solution, we light up. So across each of the pre-specified fit statistics, we meet the criteria indicating good fit. Therefore, we select the six factor model for going forward. So this is what it looks like. We have 6 different factors around cognition, mobility, self-care, getting along, life activities, and participation. You can see the factor loadings for the items in each of those, and then a visualization. So what would we like you to take away from this work thus far? So first, the 12-item WHODAS is reliable. From the Chromebox Alpha 0.93 and the item loadings, we see that there is strong internal consistency in populations affected by both displacement and conflict. This is a key question that was motivating our work. Second, we find that the confirmatory factor analysis does support a 6-factor model. And again, those are cognition, mobility, self-care, getting along, life activities, and participation. Third, we came in hoping to explore a bit around ceiling and floor effects. And we did find some indication around self-care. These were the ones the items I flagged earlier that had 0.97, 0.91. These are the lowest means. So perhaps self-care as a factor is important in differentiating perhaps a medium and high impairment. In this population, we were not there, so we can't tell. We have additional analyses planned to unpack this some more. We did not at present identify other ceiling and floor effects, which in itself is an important finding. And then we'd be remiss if we didn't go over a few of the limitations. So one of the strengths of this work is that we were able to pool primary data from multiple different studies. That also comes with its challenges. So we have heterogeneity in items and how they were collected, not specifically around the WHODAS, but other ones. The populations were different. So some samples were more heavily female, etc. And indication about exposure. All of this was highly variable, and that could impact our findings. So conclusions and next steps. First, psychometric evaluation is essential, especially in global mental health. And even in the absence of full validity studies with full qualitative work, we can learn a lot through secondary data analysis, and I hope this work thus far and future analyses will prove that even further. Second, the 12-item WHODAS, what we looked at here today, is reliable in populations affected by displacement and conflict. Next, we hope and plan to conduct additional analyses, some are underway, exploring associations between factors and relevant outcomes. So for example, can we learn something about the association between mobility, the mobility factor, and depression, for example? This could provide really a much more nuanced understanding than the summary WHODAS is really giving us. This is helpful for researchers, for implementer, policymakers. Perhaps there's an intervention that isn't really moving the needle on the summary score, but is around mobility or something else, and that is really important, and we'd like to capture that. Additionally, we have some IRT analyses that can explore item discrimination and population invariance. And then finally, we really think that future studies beyond this work that we're engaged in now should run confirmatory factor analyses against common factor structures. We just need to add to the literature. This will improve all of our understanding and confidence in these instruments. We really have to have confidence in what we're measuring and make sure that we're measuring what we think we're measuring, because otherwise, if we don't, how can we have confidence in any of the subsequent findings that come out of our work? So We just wanted to end with a thank you. I look forward to your questions. And yeah, thanks for being here.
Thank you, everyone. Welcome back. Now we're going to move over to discuss these two studies. And so I invite our panelists. We've got Andrea Armijos from MHPSS in Latin America. And so she is part of HIAS and worked on the Entre Nosotros project in Ecuador. We also have Dr. Amanda Nguyen, who is an associate professor at the University of Virginia School of Education and Human Development. She was a co-principal investigator for the Baby Friendly Spaces in Bangladesh, and Dr. Felicity Brown, who's a senior researcher from War Child and is the MHPSS Intervention Development Specialist for UNICEF, and she led the Nurturing Families program implemented in Jordan. And we have Michelle Ratner Castro, who's the research project coordinator from Universidad de los Andes and Palo Alto University, and he supported the community support groups implemented in Colombia. And so we invite all of you to, feel free to ask questions of the panelists who can tell us a little bit more about the studies. And we also have some questions for them if we don't have other questions that are coming from the panel, from the group. First, I'm just going to announce a question that was put in the chat, which is, what is the trauma and depression measure used in the WHODAS study? And the response is that for depression, they used PHQ-9, and then for PTSD, there were numerous measures used, the PCL-5, PCL-C, and the PCL-6. But the way that we harmonize them is we look for those that have positive, basically that met the risk criteria, and so it was a dichotomous measure that was used. And with that, let me ask my first question. I'm going to ask this of Amanda. And so we saw from the cross-study evaluation that across the board we saw inconsistent results. Particularly around functioning, coping, and overall well-being. Wanted to hear if you had any additional thoughts about underlying reasons or factors that might have contributed to this.
Yeah, thanks so much, Vicki. So Claire already started talking about a lot of this in that presentation, really highlighting a couple of key points first that are so important to remember, which is that some of these studies had very active comparison groups. And so thinking about how we interpret those results is going to differ based on if we're comparing to a waitlist control versus a comparison group where there might already be change in that comparison group. And so you need to see change above and beyond that. So that I think is one key one. We also in this study, and in this learning collaborative, very intentionally talked about the balance between locally developed measures versus kind of cross-study consistency. And we did select measures that are very typical of measures that would be selected by teams in the field that don't have time to do their own. We did, in terms of the time frame of these projects, most of them did have to get off the ground pretty quickly. And so we didn't do a lot of kind of qualitative work to develop new measures or to formally validate measures. It was very much more of a kind of a quick process. And I think where we do see a lot of the nuance is really showing why that matters. So for example, in the BFS study, which is the one I was in, so most familiar with, we measured distress using the K6, as did everyone else. And we also measured it using a abbreviated version of the International Depression questionnaire that we had used with other groups from Myanmar before. And we saw more movement on that IDSS measure than we did on the K6. And so with just very few differences in how we ask the questions, we start to see that difference. Same way in our study, we asked about subjective well-being a couple of different ways. We asked about kind of a global subjective well-being perception, and then this domain-specific one that we all used. And again, the implications change depending on which of those we look at. And so I think those are really good examples of how careful we really need to be about situating our measurement development and our measurement testing work in a really robust kind of local testing environment. Some other things that she also started to talk about, and I know Felicity and others will talk about more as well, is really thinking through the theory of change in these interventions. Because we tried to look at same measures across groups, we might not have always mapped those outcomes as closely onto theories of change.
Mm-hmm.
Along with that, I would just add also the timeline for follow-up for many of these studies was really short. And especially when we are looking at kind of preventive outcomes, or, we're just not able to get into the full interpretation of what this looks like 6 months down the road. And that's so important when we think about prevention. Does a minor reduction in distress right now actually map onto something meaningful in the future? Because that's also what we care about. We do want to measure, and reduce distress immediately, but we also want to know what that does. In our study, we were trying to look at the relationship between mom's well-being and child outcomes. You just don't see that in, in a 2-month follow-up period. But it's not that it's not important. So, so for many of those types of implications, I think we can revisit some of those later. The other thing is that we did in some of these, have this targeted focus on a PSS, a psychosocial element of a program. And many of the programs might have been broader. BFS, for example, is situated within integrated nutrition centers, where they also refer to a number of different resources, gender-based violence supports, nutrition supports, more high-level psychiatric care. And so really thinking about what is the need being met by our program that we were evaluating, and what are the needs that were not being met in this broader system, or that we weren't really measuring in our program. And I think maybe Felicity, I don't know if I can throw it over to you to talk a little bit more about that, because I know we've talked about this a bit as well. But I think it's also, getting into this broader system, and how much are we moving just one little piece of a system where we really need to be making broader system impacts.
Mm-hmm. Yeah, thank you so much, Amanda, for your thoughtful response. I will, pass it over to Felicity to address that. And then I also have another question for Felicity. So Felicity, you want to take that on?
Sure. Yeah.
You can,
starting with Amanda's question. Yeah.
Yes,
So in our study in Jordan, which was the family focused intervention, before we did the pilot randomized control trial, we also did a small case series study where we followed a smaller number of families. So 12 families, we followed them a bit more closely throughout their experience of the intervention. And when we looked at the quantitative data, it's only 11 families and one dropped out. It's only 11. So we don't have kind of a huge data set to do kind of complicated statistics. But when we visualized the change in those families on different outcomes and also with different family members, just kind of plotting it and visual inspection, one method of kind of case study analysis, we grouped the families into different kind of profiles. And there was one profile of families that when we then kind of independently looked back at the qualitative data and session notes and so on, there was this group of families that really started out highly distressed and remained highly distressed at the end of the intervention. And the thing that really stood out from the qualitative data with those families was that they had these other urgent unmet needs. So whether that was, commonly financial, also health needs and so on. So I do think this is something that we need to kind of integrate more systematically into our studies as well, to learn more about how we can address those.
Yeah, thank you for that. I also wanted to ask you about assessing the effectiveness of community-based, intervention programs. And, we've talked a little bit about measurement. And so, we wanted to hear a little bit more about your thoughts on specific indicators and metrics you believe researchers and implementers should be prioritizing, particularly in light of the complexities across, a lot of these programs, how we can ensure being able to correctly capture the short-term and long-term impacts of individuals and communities. And so please share your thoughts on that.
Great. And I think my thoughts have largely been mentioned by Claire and by Amanda, but I'll just kind of elaborate on a couple of them. So I think Claire mentioned, the importance of mixed methods research. So really, we can use that qualitative data that we collect either before the intervention or through our piloting of the intervention to really inform, to kind of learn first off, what are the priorities that we want to be measuring in terms of outcomes for the local community. And then also what are the potential changes, either positive or negative, that we might see through the intervention that, we might not be actually capturing in our questionnaire measures. So I think this mixed methods approach is really key. And, also, as Amanda mentioned, the kind of developing a theory of change to kind of target the measures according to the theory of change. I think it's really important for this to be done in collaboration with the local community, so that, this is locally informed and the measures are kind of selected based on those locally informed outcomes, and, also having community members involved in either developing new measures or adapting existing ones.
Mm-hmm. Mm-hmm. Yeah. Great. Thank you for that. And now I'm going to ask Andrea about some of the scale-up activities that have been, done for some of these studies. We wanted to hear a little bit more about strategies, that you might have around scaling up interventions to other sites. And I understand HIAS has been doing some of that work.
Thank you, Victoria. Actually, I agree with Felicity because based on our experience, I could mention some strategy for scaling up, but I would like to start with the community involvement of the in the process. That is a central part of the learnings that we have with this kind of process. For the design of Entre Nosotras intervention, the joint design of the intervention was essential. In this sense, for scaling up, I think the involvement of the community is also a crucial point to make the necessary adaptations according to the target population. For example, here in Ecuador, through the Swiss cooperation within the framework of a regional project, and scale up of Entre Nosotras is being carried out in border localities, in Tulcán and in Huaquillas, specifically focusing in gender-based violence survivors and women at risk. To achieve this, in the training phase, some work is done adapting the language, the examples to these specific and specificities of the population profiles. The same is happening with another project with the United Nations Population Fund in Esmeraldas, another border city, oriented to women in risk in a high conflict zone.
Mm-hmm.
Another important recommendation is to keep the community facilitators actively involved in future applications and advocacy process. For example, in Ecuador, in Guayaquil, also, we have worked with Entre Nosotras with a grassroots organization that provides psychosocial services also. So the process was to strengthen their capacities within the training of Entre Nosotras methodology, but not only with HIAS staff, but also with the community facilitators that actually have been part of the research project as trainers. So also, it's important to include them in this advocacy process. For example, recently they have participated in a webinar, in a regional webinar, sharing their experiences with the methodology and its implementation, with in this webinar regarding community intervention with women. I think another important recommendation or strategy is that this community-based intervention should not be as standalone interventions, but have to be integrated in a wider system of protection. As these are community-based intervention, it is very positive to frame them in broader community relationship, which allows them to be included in a more natural and culturally adapted way. So also in that way, those interventions actually promotes the empowerment of the people in the community. For example, another scaling up that we have done in Ecuador is in Santo Domingo, and within the framework of the community empowerment process, the community actually identified this need of women in the neighborhood to work in their well-being. So after the community actually identifies this need, the Entre Nosotras process, it's identified as a possible intervention. And after the training of this methodology, the community actually identifies the need to implement this strategy for adolescent women in the community. Obviously, that is only an idea that is searched, but it's really important how the community understands itself and how they want to work within the community.
Mm-hmm. Thank you for that, Andrea. We don't have too much time left, so I'm going to move us over to the lightning round question. You know, we are very fortunate today. We have funders in the room and system leaders in the room. So I'd love to hear what your thoughts are, all of you, on you know, your experience in terms of the project, and then recommendations you have for funders and policymakers, you know, as they contemplate future program and policy initiatives. So with that, I'm going to, you know, put it back out to all three of you. You know, Amanda, you can start, and then we can move to Felicity and Andrea.
Yeah, sorry, I was looking for Michelle because I didn't see him on here. So
I didn't see him also.
Yeah, so in terms of recommendations, you know, I think that where we will see change in this is always obviously through kind of where the money is going and how the money is being allocated in those decisions. A lot of what we've already highlighted, really emphasizing equitable partnerships. And part of that is a long-term investment process. Same as looking at these kind of system-wide changes and looking at these longer-term prevention. That all requires funding timelines that right now do not map onto research timelines or development timelines or program timelines. And so, you know, for example, like 9-month funding for a project evaluation is going to be really difficult to do a lot of meaningful movement in the way that we'd all like to see. So I would just recommend continuing to rethink our funding priorities in ways that match on to how we can best really move the field forward scientifically.
Thank you for that. That's so important. Felicity?
Yeah, so I would echo a lot of what Amanda said. And yeah, I mean, I think in terms of that kind of long-term thinking as well, I think we need to be moving away. You know, these projects and evaluations of specific interventions are really important to provide the evidence for what we're doing. But I think we also need to think beyond specific projects and think more about the systems change that Amanda mentioned, including kind of building a workforce, a sustainable workforce to implement these interventions and you know, and integrate them into existing structures. And yeah, I think really investing in kind of long-term partnerships as well. You know, often in these short funding cycles, we are creating new partnerships that then may or may not be continued depending on the funding, you know, and there's a lot of missed opportunities there to build on the lessons that we've learned and the momentum that we've gained with kind of iterative, you know, programming and research. Yeah, over.
Thank you. Thank you. Yeah, so important to have more long-term commitment and vision. Thank you for that. Andrea?
Thank you. Well, I agree with what Amanda and Felicity said, because if we are talking about the community-based intervention, those processes are actually pretty long to work in. So if you want to do a really good work and have this impact and the sustainability, it's really important to think in maybe multi-year funding and so on. Over.
Yeah, thank you all. Thank you all for such a great discussion and your thoughtfulness about how we can move the field forward. We've learned a lot. We are, you know, nearing the end of our time, and so I just wanted to share with you some of our next steps. You know, we want to invite you all to join our ISC mailing list so that you can learn more about upcoming webinars, events, and collaborations. We've got a QR code here that you can scan to sign up. You can also just email any one of us, myself, Weanne, Emily, Pekka, or Sam, who's also on this call as well, and some of you might have already had contact with. And then also, you know, if you are interested in presenting your work at upcoming ISC meetings or webinars, please feel free to contact us. We would love to explore collaboration opportunities on projects. And if you're interested in using any of the data that we've been compiling across these studies, we have a repository for our MHPSS data. And so we welcome you all to, submit proposals. And we have a team of collaborative members who will review and provide approval for those. And you can reach out to Weanne Estrada to get more information about that. And lastly, please check your inbox for our post-meeting email, which will contain details about today's presentation, future actions, and a survey, which is very important because it helps us understand what you want to see. And so please interact with us, share what your thoughts are. And now I'm going to pass it over to Emily, who will close us out. Thank you.
Thanks, Dr. No. Thank you, Vicki. And I just wanted to say, as we wrap up, a huge thank you to City University of New York and the Center for Innovation for Mental Health, and to Weanne Estrada for all of the leadership and support, to the Learning Collaborative for making this possible. And thank you all to the members and presenters today for your time and excellent presentation. So as Vicki mentioned, we look forward to hearing from you and look forward to your engagement in future meetings. So thank you and have a wonderful day.
Thank you.
Thank you.